Hello and welcome to Owen Mitchell's first webinar in a three-part Let's Talk About Stroke mini-series. I'd like to thank everyone for joining us today, and I would like to give particular thanks to our guest speakers for agreeing to take part in what we hope will be a really informative session. My name is Katie Warner. I'm an Associate Solicitor in the Medical Negligence team at Owen Mitchell, and I am part of the Owen Mitchell Stroke Special Interest Group. As a group, we collate our experience of dealing with stroke cases to identify trends in treatment shortcomings, utilise the best experts available, and ensure that we get the very best outcome for our clients in terms of their rehabilitation. We're very proud to be partnering with the Stroke Association in delivering this session today, and would like to extend a warm welcome to their support workers and users. Thanks to the government awareness campaign, which Dr. Lieberman is going to touch on today, even if we don't work in the field, most of us are familiar with the initial signs of stroke and aware of the need to access treatment as quickly as possible. But what happens after discharge from hospital? Through our work and hearing our clients' experiences, we understand that leaving hospital is often the start of a long and difficult road. The direction is unclear, and there are often few, if any, signs directing the patient to the next stage. It is little wonder that patients and their families can feel lost, particularly when they have wide-ranging, significant needs which have to be met in a community setting. The purpose of today is to shine a spotlight on the different services and resources available to stroke survivors and their families within the community. We hope that you will leave this session with a clearer understanding of where the road to rehabilitation can lead, resources and treatment available, and how to access them. We will be hearing from Dr. Jonathan Lieberman, who is a GP, Sarah Becksworth, who works for the Stroke Association, and Owen Mitchell's Support Rehabilitation Coordinator, Leslie Pointer. There will be an opportunity for questions, and we propose to deal with those by way of a Q&A at the end of the session after all of our speakers have presented. Thank you to those who have already submitted questions. We will do our best to ensure that these are answered. And if you haven't already asked a question, don't worry, it isn't too late. We are using Slido today, and you can ask any questions you have as we go along using the QR code on this slide or by entering the code #LifeAfterStroke. Just a quick tip for anybody who hasn't used Slido before, you can download the app from the Apple Store or Play Store, and it should be relatively straightforward from there. The session is going to be recorded, so if you need to leave early or would like to share the webinar with colleagues who've been unable to attend, you will be able to do so when the recording is circulated after the event. I think that completes housekeeping, so I'll now hand over to Dr. Lieberman, who's going to give an overview of stroke and the role that the GP plays within the rehabilitation team.
Hi, good morning, everybody. I'm assuming that you can see my slides. The first one there is just a little bit about me, who I am. I'm a GP, and as you can see from the fact that I qualified in 1982, I'm ancient, which means that I have a lot of experience of dealing with strokes. So I'm just going to go through a few things about strokes from a GP perspective. And we'll just give a little bit of an overview first of all. There's two types of stroke, really, as far as we are concerned. There's the ischemic stroke. I apologize for the American spelling over here. It's correctly spelt over here in ischemic with an A. Ischemic means that there's not enough blood getting to the brain, usually caused by a blockage, something like a blood clot. The other type of stroke is a hemorrhagic stroke, where a blood vessel bursts and then you have a bleed on the brain. Either of those things causes damage to the brain, and that's when you get the symptoms of the stroke. So the two types of stroke is very important to differentiate between them as doctors, because the treatment for them are completely different. One, you want to stop the bleeding, and the other one, you want to stop the clot. So it's very important for us as doctors to know which one we're dealing with, and that's dealt with by CT scan usually. From our perspective as GPs, the story of stroke begins before the stroke occurs, and that's something we call primary prevention. Prevention is better than cure, says the old-fashioned saying, and it's absolutely true. What we would want to do is to try and prevent strokes in the first place. And the things that we can do as doctors and patients between us as a team is to try and reduce the risk of a stroke by looking at the risk factors and reducing them. So the main things that we can do are listed here on this slide. We can reduce blood pressure. High blood pressure is a risk for a stroke. It's a risk for both types of stroke, actually. High blood pressure is a risk for a hemorrhagic stroke, because if the pressure is high, then a blood vessel could burst. But it also is a risk for blood clots in the circulation. So treating blood pressure is very important. Anticoagulants, that means blood thinners. Now, those are used in certain situations. For example, if a patient has atrial fibrillation, which is a heart condition where the heart rhythm is not quite right, that can cause blood clots. So any condition where we think there might be blood clots likely to be caused, we can try and prevent that using these two things: anticoagulants and platelet anti-aggregants. It's a fancy name. Those are both things which reduce blood clotting. This is a very fancy name: 3-hydroxy-3-methyl-glutaraldehyde coenzyme A. Wow, reductase inhibitors. You might know them as statins. Simvastatin, atorvastatin, Lipitor. These are all names of statins, and they, of course, reduce cholesterol and fats in the blood. Fats in the blood can build up, cause plaque, and can cause blockage in blood vessels, and that can cause a stroke. So people who have high cholesterol, we would want to think about giving them statins to reduce that in order to reduce stroke. Probably the most important one of all is smoking cessation. Smoking is a very high risk factor for a stroke, so we would want to stop people smoking as much as we possibly can. Dietary intervention, weight loss, and exercise, these are all things that we can do together as doctors and patients to reduce the incidence of stroke in the first place. So all of us who not yet had a stroke, we want to try and prevent that. These are the things we ought to be looking at. Prevention's better than cure. If somebody is unfortunate enough to have a stroke, this is the NHS stroke leaflet that I've put up there. We're all very familiar with this by now. FAST: face, arms, speech, and time. Face means if you've got a droopy face like this lady here, that means that the muscles in the face are not getting the nerve to them properly. Arms: can you raise both arms and keep them there? That's weakness of the muscles. Speech: have you got slurred speech because the muscles are not working in the mouth? And time is of the essence. Don't mess about. Call 999. These symptoms of a stroke are very familiar to us all now, and it's just a few seconds worthwhile just reminding ourselves of that. What do we do if we have a stroke? How do we manage a stroke as doctors? Well, as I stated a little bit earlier, it depends what type of stroke we're talking about. Is it a hemorrhagic stroke or an ischemic stroke? If you have an ischemic stroke, it might be possible to remove the blood clot either physically or chemically. Clot busters, those are the headline name for these drugs that are given. They're called thrombolysis, really, but clot busters sounds much more exciting, doesn't it? But the important bit for us is this bottom line, the bottom bits here, which are underlined in bold. Everybody who has a suspected stroke must be admitted to hospital and should be in a specialist acute stroke unit. This is a requirement now under NICE, the National Institute for Clinical Health and Clinical Excellence, and it's very, very important because specialist acute stroke units deliver the best care to stroke patients and get the best outcome in the end. So it's very important that patients are admitted to hospital promptly for treatment and to a stroke unit as quickly as possible. Right, there's thrombolysis, the clot buster. It's a drug which is injected. It's ridiculously expensive, and it only works if it's done within a very short period of time, 4 or 5 hours, and therefore it's very important that patients who who may have a stroke are got to hospital as soon as possible, because once that 4 or 5 hours has passed, it's not recommended to do the stroke busting, and the outcome is not as good. And that's why the slide I showed you earlier with the fast on it, that's why whoever made that clever mnemonic made it as fast, because we have to act very fast. Now, what we must do is to make sure that we're not going to give this stuff to somebody who's had a hemorrhagic stroke, because what that will do is make it worse, because they will cause the bleeding to be greater. So a person who has a stroke will go into hospital and have a CT scan as soon as possible, very, very quickly, because you want to know which type of stroke it is. If it's an ischemic stroke, you've got a clot there and you want to bust that clot, you've got to act fast. But you can't act so fast that you do it before you know what you're dealing with, otherwise you can make it worse. Another thing that you might be able to do is to actually take the clot out. Now, this is not very often done, but if it is done, you can actually physically remove the clot. It's a very difficult surgery. It's done through various types of instruments here, which sort of suck out the clot and take it away. Again, not the kind of thing he's done all that often, but if it does, it can be very successful at restoring the flow of blood to the brain. Now, we talked about primary prevention before. Now I just want to spend some time talking about secondary prevention, because that's also very, very important. Now, what this means, somebody who's already had a stroke or a TIA, which I'll come to in a minute, a transient ischemic attack, what you want to do is to try and prevent another stroke, or try and prevent it getting worse. And it's not dissimilar to our primary prevention. Aspirin is an antiplatelet drug. It reduces the stickiness of the platelets and therefore reduces the blood clots that cause. Antiplatelet drug is another type of antiplatelet drug that's not an aspirin. Clopidogrel is the most common one. Plavix is another name for it. Cholesterol lowering drugs, that's our statins. An aggressive treatment of hypertension, smoking cessation advice, diet and exercise. So you can see it's pretty much the same things that we talked about when preventing a stroke in the first place. It isn't rocket science to work out that we should be doing those to prevent a second stroke, but what we do here is we're much more aggressive. Somebody who's had a stroke will have higher dose of aspirin, they'll have a higher dose of statin to try and get their cholesterol very, very low, will be really aggressive in the treatment of their blood pressure to make sure it's as low as it can be without it being too low. And we will absolutely sit on you until you agree to stop smoking, because smoking is the worst thing that you can do if you've had a stroke. Diet and exercise, of course, are important for general health and also for preventing strokes. So this is the most important things that we as GPs can do, and patients who have had a stroke should be expecting from their doctors to give them these things and to be on at them all the time. Every time they come, if they're smoking, they should be given help to stop smoking and advice how to do it. They should be given advice about their diet and exercises. They should be having their cholesterol measured regularly, and they should be on these antiplatelet drugs. I'm running out of time a bit, so I'm going to just quickly talk about this. This is a slide really which is more interesting for the lawyers than the patients, because lawyers have also got to eat as well, so they have to have the clients, and what they're looking for is when we doctors do things wrong, these are the kind of things that we fail to do. Doctors don't always take a proper history and examine the patient properly, and they're not always as good as they should at getting people to hospital in a timely manner, and they're not always as good as they should be in secondary prevention. And you should be, as patients, you should be aware of what your doctors should be doing, and if they're not doing it, you should make sure that they do and ask them for these secondary prevention measures in particular. Once a person sadly, let's talk about TIA first. The TIA is known as a mini stroke sometimes, and it's a temporary disruption to the blood supply. A stroke is when something's happened and there's been permanent damage. A TIA are the similar symptoms to a stroke, but they only last less than 24 hours and they get fully better. It's a warning. Somebody who has a TIA needs to be secondary prevented. You need all of those things that were on that previous slide as aggressively as possible to try and prevent a big stroke. So a person who sadly has a stroke, then we would need rehabilitation. And rehabilitation, of course, is a slow process. Strokes can, generally speaking, improvement happens on a slow linear process, not a linear process, it's a reverse exponential process. So that means that the most recovery happens in the first few months. And as time goes on, the recovery gets slower and slower. And usually after about 2 years or so, that's about as much as recovery as you're going to get. It's important to have a full rehabilitation team, and that's why the stroke units are so important. And a person who has good rehab will have specialist rehabilitation nurses, specialist physiotherapists, occupational therapists, speech and language therapists, dietitians, social workers, psychologists. All of these people are very, very important in the team, and they work as a team because a stroke is a devastating event, and it can affect all sorts of different parts of the body, not just the physical manifestations of a stroke where bits of the body don't work properly, but also it also affects the psychological effects of the patients as well, and of course not just the patients but their loved ones, their families, and all of these people are very, very important in the stroke rehabilitation team. Anybody who's had a stroke should be able to have access to all of these people if they need them as part of a stroke team. I was given 15 minutes. I think I've used about 14 and a half of them. And I think that is probably it. Yes, there you are. Wow. A whistle stop tour through stroke in 15 minutes. I'll be available for questions at the end if anybody wants to ask any questions.
That was really helpful. Thank you. And thank you very much for keeping to time. I didn't think it was going to happen, but you managed it. Right, we're now going to hear from Sarah Becksworth, who works for the Stroke Association, who's going to speak to us about the fantastic work the association does and how it can assist patients in accessing the rehabilitation that Dr. Lieberman's just outlined.
Thank you. Hi, good morning, everybody. So standard's been set by the doctor. Let's see if I can keep the time in the same way. I just want to start with a little bit about me. So my role is service delivery lead. I work for the Stroke Association. I'm based in the east of England. I live in Newmarket, which is in Suffolk, opposite end of the country to Dr. Lieberman. And this is my dog, Penny, who's actually making noise in the background at the moment. Hopefully she won't break in too much. I've worked for the Stroke Association for just over 10 years in a variety of different roles. Prior to that, I used to work in lottery distribution, so not giving away the big checks, unfortunately, but investing in projects that were there to make a difference to good causes. And that's probably part of the motivation why I work for the Stroke Association now. But before joining, I had no prior experience, no family history of stroke. So it's been quite a steep learning curve, but absolutely fascinating area to work in. So in the few minutes that I've got, I'm hoping to talk a little bit about the impact of stroke, to share a stroke story with you, because we think it's really important to have the voice of lived experience in every conversation, and also to share with you a little bit about what the Stroke Association can offer that will hopefully help people as part of that recovery journey. So I'm just going to start initially talking about the impact of stroke. So at a population level, you can see that there's actually a huge financial and economic cost to the country. There's over 100,000 new strokes every year and over 1.3 million stroke survivors living in the UK today. And that second large number actually is testimony to the fantastic stroke treatment that is available now. More people are living as a result and living with less of a disability, but it still is a huge economic and social cost to the people who suffer from a disability. About 2/3 of people leave home with some form of disability. It's still the fourth biggest killer in the UK, and there's an estimated economic cost of around £26 billion each year. But the bit that I wanted to focus on a little bit more really is about the personal impact to the individual that's had the stroke. Working for the Stroke Association has given me a real appreciation for just how marvellous and complex our brains are. However, it does mean that the damage in different areas can cause different effects, with some being more common than others. All strokes are different, and for some people the effects may be relatively minor and they might not last for a long time. They may resolve, but for other people they may be left with more serious and long-term problems. So a stroke can cause problems with physical activities like walking or getting dressed due to mobility issues, muscle weakness, stiffness, and also changes in sensation, which can cause discomfort. After a stroke, a person might experience problems like fatigue is incredibly common, also balance issues or joint pain. Unfortunately, most people do make significant improvements in the months following their stroke. But it's also, there are some more hidden effects of stroke that sometimes can be the most difficult for people to deal with. A stroke is a sudden and shocking experience, so it's likely to have an effect on someone's emotional well-being. And for many people, they feel that they've lost the life that they had prior to having a stroke. It's not uncommon for people to have feelings of shock, denial, anger, grief, and guilt sometimes. That's all quite normal when people are faced with such a devastating life change. And dealing with these emotions can be really hard. Everyone does it in their own way. But tiredness and fatigue can also mean that people behave differently. They may be less active or less talkative. They might experience frustration at not being able to do the things independently that they could do before. That can build up and manifest itself maybe in anger or even aggression at times. And a stroke can also affect the way that your brain understands and organises and stores information. So we talk about the cognitive impact of stroke. And every second that our brain is working, we receive huge amounts of information from the world around us, which our brains have then got to understand and organise and keep. And if the part of your brain that processes this information is damaged, then that's going to cause problems. So people sometimes have problems with memory, with concentration, and also thinking. It's very common. And most people have difficulty of some sort, perhaps unsurprisingly. And then again, when we communicate, our brains also have to complete a series of tasks. Again, different parts of our brain are responsible for each of these tasks. And if any one of them is damaged by a stroke, it can cause problems with communication. We talk about something called aphasia, which is a complex language and communication disorder that results from damage. That'll be in the language centres of the brain. About 350,000 people in the UK today have got aphasia as a result of stroke. And around 1/3 of stroke survivors have some sort of problem. And communication might mean speaking, reading, writing, but also things like telling the time or using technology. Dealing with money can be affected, and also understanding what is being said to somebody. And it doesn't affect their intelligence. People with aphasia still think in the same way, but they may have difficulty in communicating their thoughts easily or understanding at times. About 2/3 of people have some sort of vision problems after a stroke. Vision loss can affect your daily life in lots of different ways, as you can imagine. So it might be more difficult to do things like reading or shopping or just watching the television. And you might need support to return to work or help with travel or new ways of doing your job. And sight loss, perhaps unsurprisingly, also brings with it an increased risk of some sort of emotional upset as well. Dr. Lieben also talked about how the family might be affected. So stroke can impact on your family roles or relationships. And if someone close to you's had a stroke, they're going to need that ongoing help and support after they return home. But taking on caring responsibilities is a really big decision. And it's often something that people do naturally as part of a relationship. But it can be really challenging. And it also takes time and energy and can take its toll. And we hear from carers quite often tell us that they feel guilty, but they also feel overwhelmed, exhausted, and potentially isolated. So again, just a few figures on the slide there in terms of what stroke survivors tell us. And we did a survey in 2018. It was the largest ever survey of stroke survivors and carers to find out more about their lives, and we published some reports as a result of it. About 11,000 people who'd been affected by stroke took time to fill in the survey, and 1/3 of them who shared their story told us that they had to give up work as a result of their stroke, and just under 70% felt that their stroke had a significant impact on their independence. but it's not all a bad news story. And hopefully I'll be able to tell you a little bit about how we can make a difference. Bear with. Okay, so on the slide there, you can see some of the people that we've worked with over the years at the Stroke Association, just some examples of people who have who've made successful recoveries and improvements in their lives. In a few moments, I'll share a video with you. But just to say that there is hope. Recovery can be tough, but with the right specialist support from the clinical teams that the doctor described, but also with the courage and determination of the stroke survivors, our brains can adapt after stroke. Brains are amazing. They've got the ability to rewire themselves, so allowing stroke survivors to improve skills such as walking, talking, or dexterity. The process is called neuroplasticity, and it begins after a stroke and can carry on for many years. But of course, not everyone can make a complete recovery. But a lot of people do make progress with individual goals and things that are important to them, like getting stronger, becoming more mobile or independent. And with the right support, people can get confidence and find new ways of doing things. And time again at the charity, we've seen thousands of people adapt to a new life after stroke. So I'm going to ask Donna just to put on a brief video of a young lady called Alicia, who was 26 when she had a stroke. She was a primary school teacher. But hopefully her story is a good example of the recovery that people can make.
I know lion, giraffe, elephant, rhino. That's a tricky one. My mind was not coming together. Inside, I'm stuck. The frustrated is not because anyone's done it, it's just because I can't say it and it's not coming out. Bench. Oh no,
it begins with S. So what is that? It's 5 letters.
I think it was when I was at the rehab, they must have mentioned aphasia. Now what I know at this point, what aphasia means, you're intelligent, but you do have to start from the beginning. I didn't really understand this is a stroke. The doctors were coming and saying, you might not wake up, you might not be able to talk, you might have a wheelchair, it could be quite severe. I was a teacher for 5 years and that was honestly my passion, but it took a long, like a year to accept that no, I don't think I can be a teacher. It's hard to even understand. I guess you will never. You can only try your best. I smile, but I do have a lot of tears or upset or worried. I guess anxious.
They don't really tell you that this is going to be an ongoing thing for the rest of her life and your life.
Because sometimes I feel that I'm in my own world, while everyone else is moving on. This is a scrapbook for all my memories. The reason why I kept it is because, like, look at this before, how severe it is, but now it's, I guess, better.
It's like to remember how far you've come.
Exactly, yeah. I'm just trying to think about, like, when I have the sad things, what will I do to make it better? Football.
Yeah, but the Americans might call
Soccer.
Soccer. Oh,
Football.
actually, they did call it football.
I don't think you know how to do speech and language. I'm really happy with this new things I'm doing. Like, I've accepted that I'm not a teacher, but I am a teacher because I'm volunteering. I think everyone can do anything they want to do. It might take time, but I believe you can do it. Stand up and don't give up, whatever you want to do. I feel so grateful that the Stroke Association has really helped us so much. You get to meet new people who have had a stroke, but now I am volunteering for the Stroke Association, and I honestly love it. You have to think that we are alive, but how can we help others now? We're lucky. We have to remember, imagine that point. I thought I was going to die. They said that. But now I'm here today. I can walk, I can talk, I can learn, I can do so much. Like, it's just, yeah, I guess I'm quite grateful and blessed in that sense.
Hi, thank you. I hope you enjoyed watching that video. It's I enjoy watching them and looking back, and it reminds me why the work that we do is so important. So I want to spend the last few minutes talking to you a little bit about the Stroke Association, the way that we try to make a difference. So our vision is for there to be fewer strokes and for people that are affected by stroke to get the help they need to live the best life that they can. And to help make that possible, we provide specialist support, which I'll talk about in a minute. But we also fund critical research, and we campaign to make sure that people affected by stroke get the very best care and support to rebuild their lives. So I just wanted to touch briefly on the range of things that we've got, and I've got a summary slide that I'll be able to share afterwards that kind of brings this all together in one place. And you can also find out information on our website. Just to let you know about our stroke support services that help hundreds of thousands of people who are going through one of the most frightening experiences of their lives, and also to rebuild a life after stroke. These aren't clinical services. This is about what happens after you've finished working with your therapists and the doctors. So many areas, but not enough of them. We do get funding from either health or local authorities to deliver our life after stroke services. So the Stroke Recovery Service. Our local coordinators can provide emotional support and practical high quality information following a stroke and answer the lots of questions that people have. People often, when they come out of hospital, it's been a bit of a confusing time. They've got a number of questions and they really just want to try and understand a bit more about what's happened to them, and also perhaps not unsurprisingly, people are really terrified of having another stroke. So we can talk to them about secondary prevention, but we can also support them and give them the confidence to access the opportunities that are there. So we work alongside people to attain their goals. That might be about returning to work or managing their condition, or things like building back social support and looking at interests. We can also offer specialist support to stroke survivors who are living with communication difficulties such as aphasia. And we also work with families, of course. We've also got something called Stroke Association Connect. So that's in areas where we don't have the services that are commissioned. It's more like our helpline, but with outreach. So where we get referrals, then we can reach out with an offer of information and support in the early days following hospital discharge. We've also got something called Here For You, which is a volunteer-run telephone service to help stroke survivors who are feeling lonely or isolated. And we connect our stroke survivors and carers to trained volunteers to offer support. And sometimes these, it might be a kind of a social activity, but some people want to someone else who's had a stroke. And connecting people with one another is one of the biggest things that we can do in order to help people realise that they're not alone. Our helpline responds to calls and support stroke survivors and their families and carers by providing a place to get information about services and also to be heard and for people to talk through their situations. And we do a lot of work building stroke communities. We've got a network of stroke groups, and they're really vital in the role of recovery of stroke survivors. If you think that people have spent a relatively short period of time in formal services, they're living a life with stroke afterwards. We also connect stroke prevention professionals and leaders with the stroke communities to make sure that that voice of lived experience can kind of inform their work. We've got a digital platform called My Stroke Guide that's got practical tools and loads of videos about stroke, and so people again can see and hear information that's useful to them. There's also a dedicated section on there where there's an online forum. People can again connect with one another and talk to people with lived experience. And then also, just to let you know, we've also got a childhood stroke support service. Around 400 children a year, believe it or not, actually do have a stroke. There's a different pathway for them, but we also recognise that them and their families do need support as well. And we've got lots of leaflets and publications. So you think of it, we've got a publication around it, and our website's a great place to go for some of those resources. And I'll just show you as a little slide that I've created that can possibly be shared afterwards that kind of brings together a lot of those different things so you can see. But I'd recommend that you take a look at our website or give us a call on our helpline. Thank you.
Thank you very much for that, Sarah. It was really informative and a really fantastic resource. I do encourage anybody to go and have a look on that website if they haven't already done so. We have had some questions coming in, so thank you for those. Please don't forget about Slido. The QR code was provided at the beginning, and you can otherwise use the code #LifeAfterStroke. Finally, I'd like to hand over to Leslie Pointer, who's a nurse by background and now works as a support rehabilitation coordinator at Irwin Mitchell. Leslie's worked with a number of clients affected by strokes and is going to outline some of the statutory services she's been able to assist them in accessing. If I can pass over to you, Leslie.
Hi, I'm Leslie Pointer, and as Katie says, I'm a nurse by background. For many years, I worked in the NHS before I transferred out into the private sector and worked within rehabilitation. I now work for Irwin Mitchell as support and rehabilitation coordinator, and we are a team of 12 at the moment and looking to grow that. And we support our clients who have suffered serious injury or illness on their journey in accessing rehabilitation services and helping them to make some sense of what's happened to them. People following stroke can often find it quite a maze in accessing services, and they just need some support in detangling the confusion. They can find it quite overwhelming. So the support and rehabilitation service is made up of many different professionals through from health, social care to education. So it's quite rich in its knowledge and skills that we can draw on to best support our clients. We can support in many things. I've made a list on the slide and we're not limited to that, but just some key features. We can assess the need of clients and coordinate the team around them in delivering those support services. We can liaise with local services such as adult social care when a client needs more support with their care and accessing of services. We very much signpost on to other services such as Stroke Association. They're a really useful resource to our clients, provide lots of information and support. We can also provide support on day-to-day issues such as budgeting, coping strategies, general wellbeing advice, and Irwin Mitchell offer a welfare benefits team service, and we can make referrals into that for our clients to receive support in checking benefits, making sure that their entitlement is optimised and looking at other grants. Mental health and bereavement support is also part of our role, and we very much signpost on to other services to support with that. And some of us have particular skills in end-of-life care, support and planning. So all of those, it's not exhaustive, but some of the key features of the SRC service. I'm just going to give you a quick whistle-stop tour of a couple of case studies, just to try and give you a flavour of some of the support that we can offer to our clients. So in case study 1, this is a 64-year-old female who suffered a hemorrhagic stroke. Unfortunately, this left her with some quite severe deficits in mobilising, and she required full support in her activities of daily living, including mobilising and all transfers. Originally, after suffering stroke, this lady transferred to a care home as she felt that she didn't want to be a burden on family members, friends, and she couldn't really see a way through returning home to independent living with her family. However, in September 2021, this lady decided that actually she would rather be in her own home and receive care there. And given the fact that we were actually still having COVID restrictions in place, that presented challenges all by itself in terms of getting care packages in place and onward support. However, that did materialise and she did manage to get home. Subsequently, there was no support in place, and she required referral to the neurological occupational therapist and physiotherapist team for support with assessing mobility, equipment use, and ensuring that aids were in place. Out of that, we needed to then explore a disabled facilities grant to look at adaptations for this lady's home to enable her to access basic facilities such as bathrooms and to access the outside of the property, which in turn gives her access to the community, which she was a large part of pre-stroke. These adaptations have subsequently been completed and have served to make her more independent and more in control of her own care needs, which was a huge success. She's now able to access her garden, which she adores to be in, giving her some well-being and quality of life, and also accessing the community. Adult social care, we needed to liaise with them in relation to getting care in place. I'm sure that you can appreciate that one size doesn't always fit all, and tailoring a care package that met her needs and her preferences can be quite challenging and may require more than one provider to get that right fit. But it was very much tailored to that person-centred care and meeting this lady's needs in a way that she found acceptable. Attending MDT meetings is something that we would do as a service. It helps to define that client's goal. We can advocate for them and come together as a team to make sure that that client's needs are being met safely and appropriately. This client also needed assistance with technology. I'm sure you can appreciate accessing the internet and online shopping doesn't always come as second nature to some. So she required some assistance in making sure that the equipment that she had got was suitable, and some lessons in how to access that and how to independently order her own shopping online, which was huge for her and a great success. Again, I mentioned before that Irwin Mitchell have a welfare benefits team, and an onward referral to them was made for support in application for universal credits. And that can be quite challenging all by itself for somebody who has suffered a stroke and at times is overwhelmed when she's required to access services and apply for benefits. So the benefits team were wonderful in supporting that, and that was all in place. Also, when this lady is wheelchair bound, she has an electric wheelchair, but accessing the community is not always easy. And as a service, we signpost on to local transport services that provided vehicles that were accessible for her with her electric wheelchair, and that's enabled her to get out into the community and visit friends, which has supported her well-being. And again, we would signpost on to appropriate services such as Stroke Association, because as mentioned before, they are a huge resource. So, and this lady is living well with stroke, following her stroke and all the things that come with that. She is now starting to adjust. So if we move on to case study 2, this is a 58-year-old male who suffered an ischemic stroke during a routine mitral valve operation, which left him with quite some significant mobility deficits and some cognitive deficits. He did receive rehabilitation treatment following stroke, but unfortunately, once discharged from that service in 2020, he seemed to regress backwards, and the levels of mobility that he had reached seemed to wane a little. This gentleman had care and support in place at home, but it was minimal and didn't really support him in living a full and active life as he could. So liaising with adult social care to ensure that correct assessment of needs took place and further care and support was added to his package. He was also referred to the occupational therapist who assessed the need for rails and ramps so that he could safely mobilise around his home and again access the community. In relation to physiotherapy, it was viewed that this gentleman had reached his potential by NHS physiotherapy, and therefore there was no funding for him to receive any maintenance physio to maintain the level of mobility that he currently had. He was paying for private physiotherapy at a rehab centre, which helped to support the maintenance of the mobility that he had. However, this required family and friends to enter into some interesting fundraising to fund that, and that was very successful. However, that needed very much to transfer over into the home setting. The exercises and techniques that he was learning during his physio were not actually transferring over. So therefore, the client invested in some exercise equipment just to maintain that level and keep his muscles strong so that he was able to mobilize. I needed to liaise with adult social care and provide a rationale as to why he needed support to access that exercise equipment. It's one thing to have the exercise equipment, but if you're not able to independently use it, then it's kind of a waste. And with the rationale of preventing falls prevention and risk assessing, adult social care did agree to a further 2 30-minute sessions a week where carers would attend and assist with mobility and accessing his exercise equipment so that he could join up his private physiotherapy that he was paying for with his therapy at home. Also, this gentleman, we needed to check that his benefits were optimised, and again a referral to Owen Mitchell's benefits team was made, and he was supported with ensuring that all the appropriate benefits and grants were in place. And again, this gentleman, not an old gentleman, very young, he was a very active man before stroke, and very much wanted to re-engage into society and feel some value and worth. And signposting on to Stroke Association, Headway and local support groups such as Success After Stroke has helped him to do that. They provide lots of activities such as art classes with some physio and speech and language therapy thrown in there, which really has supported his well-being. So that's a quick whistle-stop tour to showcase the SRC service in its shortest term. I could probably sit here and talk to you about it for hours, but I will hand back to Katie and thank you for listening. If you've got any questions, please don't hesitate to ask.
Thank you very much for that, Leslie. It was really helpful. And we're doing all right for time, I'm pleased to report as well. So we've got 10 minutes now for some questions. We have had some interesting ones come in, so thank you for those. If you have got any others, please do keep sending them in. If I can start with the first question, it relates to returning to driving after stroke. So if I can hand that first of all to Dr. Lieberman to talk about, if that's okay, please.
Sure. Obviously, driving is a multifactorial action. You need to be able to be coordinated. Your limbs need to work. Your brain needs to work appropriately. And sadly, after a stroke, often that's not the case. People are often very desperate to get back to driving, and quite rightly so, because it gives them that independence of movement. But for everybody else, as well as themselves, they have to be safe to do so. And the DVLA will often want to know from people like me what we think as to whether people are safe to drive. At the end of the day, the decision about driving belongs to the DVLA, and there are driving test centres around the country. The DVLA will often ask a patient after a stroke who applies to have a driving licence again to have a test. And that's not the same kind of driving test you have when you're 17 and you just learning to drive. It's a different type of test. It's a test to see whether you are able to drive safely. And I would certainly recommend anybody who's had a stroke who wants to drive to go and have a test, even if you're not asked to do so, because it will give you the confidence to know whether or not you are safe to drive. because it's such an important thing to be safe when you drive. We are often asked questions by the DVLA. We're sent forms to fill in, and we will do that as honestly as we can, because we don't want people not to be able to drive, but we also need to make sure that they drive safely.
Okay, thank you. Sarah, do you have anything to add to that from your perspective?
No, just to reinforce. So there is a website called Driving Mobility. I think it's .org.uk, which you can go onto to find out where your nearest assessment centre is. And there should be one in each region at least, I would think. And I reinforce that message. I think it's definitely really important too, because you don't know until you get into a car. Sometimes you might have some kind of impact that you don't realise that you're not able to maybe drive in the way that you could before. So having an assessment, I think, is a really good idea. There is information on the DVLA website, but we've also got some guidance on our website and literature. But also information about alternatives to driving. So if driving isn't for you for now, you may want to find other ways to be able to get about, so it doesn't minimises the impact on your kind of daily living. But yeah, driving's a big one. It comes up commonly. It represents our independence quite often, doesn't it?
It does, yes. Thank you for that. Right, okay. The next question relates to patients being deregistered from the GPs when they go into a rehab facility for a short period of time. Again, I think, Dr. Lieberman, you're probably best to answer that question, if that's okay.
Yeah, I mean, the thing here is it's a geographical thing. The way general practice works in the UK is that you're registered with a GP in your area. So, for instance, I live in Prestwich in Manchester, so I need to be registered with a GP within that catchment area. Now, a person who's registered with a practice in Area A, who sadly then has a stroke, may be admitted to a rehabilitation unit a long way away, outside of that catchment area. Generally speaking, the catchment areas of general practice is only a couple of miles, and there isn't a rehabilitation unit on every street corner. So a patient, for example, may be admitted to a rehabilitation unit 10, 15, 20, 30, 50 miles away from their home. They then can't be registered with that GP because that GP can't provide them with the services from that distance. So the rehabilitation unit will have their own GPs who will be looking after their patients, and they will be re-registered, and they'll be deregistered from their own GP, as it were, and will be re-registered to the practice which is looking after the rehabilitation unit. Once they then go home again, they will need to re-register with their old GP back again. Unfortunately, these things don't happen automatically. It's a very old-fashioned and cumbersome system, which really in 2023 ought to be a lot better than it is now, but it isn't. So it's really, you need to be proactive. When you go to the rehabilitation unit, that you will be registered for you by that unit. When you go home again, you'll need to re-register with your GP, and they almost start all over again, and the records will then have to follow you. So yeah, it's difficult, but there's nothing sinister about it. It's just a cumbersome administrative system that has grown up around general practice since 1948.
Okay, thank you. We had some discussion, Dr. Lieberman, about the GP's role in terms of organising and accessing rehabilitation services within the community. I know that from your perspective, obviously, as a very busy GP, you are in a good position to be able to potentially offer some insight into how involved patients should be in chasing up the GPs and chasing up those referrals and seeing where they've gone to, basically, rather than just expecting the GP to come back to them when they've got the answers for them. And I wondered if you could just give us a bit of an overview in relation to that, please.
Yeah, yes, absolutely. And this is not just specific to stroke or rehabilitation either. Anybody out there who's listening who has any kind of interaction with the medical system needs to know this. And that is that unlike Katie, who will have a diary which will tell her that in 3 days' time she needs to chase up somebody who hasn't, if they haven't phoned her about a particular case, and then a month later she'll have rediaried something else. We can't do that in general practice. It just is not physically possible. So if I send off for a rehabilitation referral, let's say I send a patient off for physiotherapy, I send that referral and I have no idea whether the patient has received an appointment from physiotherapy or not until the patient comes back to me and says, I thought you were referring me for physio. I haven't received an appointment. And I'll look and say, oh, my goodness me, I forgot to do it. Or, oh, what are you talking about? I did that 3 months ago. I wonder why you haven't had an appointment. But until somebody tells me that you haven't got one, I don't know that you've got one. You've not got one. It's the same with an appointment for a hospital specialist. If I send you off for a neurology appointment and you don't get one within a reasonable period of time, a few weeks or whatever it is, a month or so, you must contact the GP and say, you said you were going to refer me for X, Y, or Z. I haven't had an appointment. And the GP will then be able to be on notice that they must chase it. But patients often expect that we will chase it and that we will know that they haven't had an appointment. Well, we don't. So this is a really sort of a bit of an eye-opener for patients to realize that. It's the same with blood tests. If you are sent for a blood test, if your doctor says to you, I want you to have a blood test, I don't know that you haven't had the blood test until you come back and tell me you haven't had it. If you have it, I'll get a result and then I'll act on that result. But I don't know if you haven't had it. Same with an X-ray, because I can't make a diary entry for every single patient to say, I wonder if Mrs. So-and-so has been for the X-ray that I asked her to go for. It's not possible. It can't be done. So the patients need to know that if things have not happened in a time span that you think they should have happened, let us know. And that goes for rehabilitation for stroke patients. It goes for blood tests. If you're on a drug that you need to have regular monitoring for your blood tests, if you know that you're on a certain drug that needs to have regular blood tests on it, let's say thyroid, you've got a thyroid problem and you're on thyroid replacement, you need to have a blood test once a year. Don't rely on the GP to say, oh, you need to have your blood test. You've got to have it every year. Put it in your diary. And after a year, if you haven't had one, phone up the GP surgery and say, I'm overdue my blood test. Can you book me in, please? It's not an ideal situation. And lawyers particularly find this shocking because they have such sophisticated follow-up diaries. But we don't in general practice. It's impossible. We're dealing with, each GP has the average of 2,000 patients. Something like 15% of those patients on any one day will have defaulted from a test or an appointment. It's just not physically possible to do it. Patients must take responsibility and let us know. We're all always happy to chase things up, but we can only chase them up if you tell us that they haven't happened.
Thank you. I think that's a really important question. I think or a really important thing to know, because I think that a lot of us are worried about taking up the GP's time and, when they've got so many other things that they need to be doing. So thank you. That's really helpful. I think that pretty much brings us to an end for today. We have got some other questions. We will try and get answers to you if you've provided contact details, if your question hasn't been asked today. There was one question that was asked in relation to fatigue. We're really conscious that it's a very, very important subject, and we are looking at potentially delivering a separate webinar on that. So we will keep that question, ask us details, and we will send details of the webinar to you as and when it's available. Thank you again to everybody for joining us and to our guest speakers today. We hope that you found the webinar useful. The recording will be made available shortly after. And if you want to share the recording with family, colleagues, support groups, or anybody else, please feel free to do so. And if you or anybody else has any questions arising from today's session, please don't hesitate to get in touch. For further information about stroke, you can go to the Stroke Association's website, and you can also go to Owen Mitchell's website, which is www.owenmitchell.com. And finally, I hope that you're able to join us for the next session in our series, which will take place next month. Thank you again for today, and I hope that everybody enjoys the long weekend for the coronation.